Look, I think that was even interesting for the guys. It's important for us all to know about it. Look after our girls. So before we move on, I just want to show you this little device. It's an Orbi-R Active, and it was developed by a blood clot patient in the UK. It's scientifically approved that if you're sitting for long periods or at a desk working or whatever, that you can put your feet on it and do some exercise, like in your stocking feet, and it's supposed to help prevent it. He's actually gifted one to everybody who attends the conference today, but they didn't arrive. So they've seemingly arrived to the office this morning. So we're in Terenure. So if any of you would like one, you're welcome to pick it up. Just give me a call and I'll arrange for you to pick it up. Okay, so just to let you know about that. And now, last but certainly not least, because it's really crucially important that we understand the medication that we're taking, particularly as people who've had blood clots. We want to prevent them, so we want to take the medication correctly. Okay, so Amy Byrne, who's Chief 2 Pharmacist for Medication Safety in Connolly Hospital in Blanchardstown. She studied pharmacy in the Royal College of Surgeons of Ireland and later went to complete an MSc in Clinical Pharmacy through University College Cork. She is currently undertaking a postgraduate certificate in Quality Improvement Leadership in Healthcare at the Royal College of Physicians of Ireland. She is passionate about patient empowerment, digital health transformation and quality improvement. She is a working member of the VTE committee in Connolly Hospital, and they're our angels. We have VTE committees in most of our hospitals. They're voluntary positions where people try and improve awareness and education within the hospital and improve safety. So thank you, Amy, for doing this, and welcome.
So hi everyone. So thanks Anne-Marie, and thanks so much to both Anne and Anne-Marie for inviting me to speak today, and it's a pleasure to speak to you all about the anticoagulant medications. So just to give you a bit of a background into my role in medication safety. So prior to taking up the post of medication safety, which I've just taken up in the last few weeks, I was a clinical pharmacist on the wards in the hospital. So I don't know if many of you have met clinical pharmacists when you've been in hospital before, but our role, generally speaking, is to review drug cardexes on the ward, so they're your chart where your medications are prescribed, and to make sure that your medications match what you were taking before you came into hospital, that there's no discrepancies between what you were taking before and what's prescribed, and to prevent, obviously, harm while you're in hospital. So my role in medication safety then is to reduce medication-related harm in the hospital, and I suppose to put measures in place to prevent harm from happening. And then as a member of the VTE committee, we're kind of reviewing our process for VTE prophylaxis in the hospital. So we want to prevent people from getting a clot while they're in hospital, because we know when you're in hospital, you're not mobilising, or if you've had a recent surgery, you are at an increased risk of a clot. So I suppose I'll touch on some of the bits that we've done so far later on, but that's just a bit of background on myself. So just in terms of different types of anticoagulants. So anticoagulant is a name for blood thinners. So you can have oral anticoagulants or injectable anticoagulants. So some of you might be familiar with the oral anticoagulants, and if you're comfortable, if people wouldn't mind just giving a show of hands if you've ever been on an oral anticoagulant or you are on an oral anticoagulant. Okay, so majority of people in the audience. So there are a few different types of ones, and the names can be a bit confusing. So we've Eliquis is one of them, and Eliquis is the brand name, Apixaban is the drug name. There's Xarelto, or Rivaroxaban, Lixiana, or Doxaban, and Pradaxa, or Dabigatran. So those 4 different anticoagulants are also called, as a class of drugs, called DOACs. So that might ring a bell, but some people are NOACs. And DOAC means it's just a direct oral anticoagulant. Before that, they were called NOACs because they were considered novel oral anticoagulants. They're not novel or new anymore. And then warfarin, obviously, is the other oral anticoagulant. In terms of injectables then, you've unfractionated heparin. There's low molecular weight heparins, so you might have heard of Inahep or Clexane. So often the injectable medicines they can be used to prevent, well, actually both the oral and injectables can be used to prevent a blood clot or treat blood clots. So the injectable medicines like Clexane you might have had if you're ever in hospital and you weren't on an oral anticoagulant. They might have given you an injection into your tummy to prevent a clot from happening. And that can either be Clexane or Inahep. So you'll see the pictures of them down the bottom there, so it might look familiar to some of you. So how do they work? So they all kind of work on clotting factors, and they stop the further production of fibrin in the clotting cascade. So what they do is they slow down clotting factors. But it's really important to note they do not dissolve clots. So if you have a clot and you're put on a blood thinner, your blood thinner doesn't dissolve your clot. It helps other clots from forming and prevents the current clot from getting bigger. So when you have an active clot, obviously there's a risk of, unfortunately, the clot travelling or other clots forming. So the blood thinners are there to prevent that from happening. But I think there is a misconception sometimes that, oh, I'm on a blood thinner, so that's going to get rid of my clot. It doesn't dissolve it, it prevents it from getting bigger and travelling. So I had 2 videos here. I can send the slides to Anne-Marie, she can share them with you on how warfarin works and how the NOACs work. I don't think the videos are working at the moment. So what are they used for? Well, we all know VTE, so deep vein thrombosis or pulmonary embolism, or a condition called atrial fibrillation. So I don't know, there could be someone here that has atrial fibrillation as well. It's basically a condition where you have an irregular heartbeat, and what can happen is the blood can sit and pool at the bottom of the heart and a clot can form, because when the blood doesn't move, it increases the risk of a clot. But I suppose for the purpose of the presentation, we'll focus on VTE. So this is just a video we're going to just play. A lot of this will be very familiar to all of you, I think, after the...
While you're sitting there, I can tell you some interesting facts about your medical condition, venous thromboembolism, or VTE for short. We say someone has a VTE when they have a blood clot in one of their veins. The blood clot might form in a deep vein of the body, usually a leg muscle. This is called a deep vein thrombosis, or DVT. Sometimes part of the blood clot can break off and travel to a narrower blood vessel in the lungs. This is called a pulmonary embolism, or PE. We use the term venous thromboembolism to describe both DVTs and PEs. Different people have different signs and symptoms of VTE. A DVT, for example, may cause leg pain, redness, warm skin or swelling. A PE can make you feel short of breath. You may cough, feel your heart beating fast or have chest pain. You may feel anxious, dizzy or faint. People can get any one of these symptoms, a combination of them, or none at all. Many people associate blood clots with long plane journeys or taking the contraceptive pill. However, most blood clots actually develop during or just after a stay in hospital. The chance of getting a VTE increases as you get older, and it's more common in people who are not moving around much. This could be due to hospitalization, bed rest, or simply a sedentary lifestyle. You're more at risk of VTE if you're overweight or obese, if you smoke, or if you're having major surgery, or if you have a serious medical illness. Rarely, there may be other unknown causes which need further investigation. And if you've been unlucky enough to have had a VTE before, there's more chance that you could have another one. If you do get a VTE, it's important to know that you're not alone. In fact, 1 in 20 people will develop a blood clot in their lifetime. I hope you feel you know a bit more about VTE now. Goodbye.
So I suppose that's just repeating a lot of information you've already gotten today. So we'll just move on to the next slide. So I'm sure you're all familiar with the blood clot alert card presented here, and I think you've all been given one as well coming in. So it's really, really important that we push this blood clot alert card across the hospitals, and that's one of the roles of the VTE committee in Connolly Hospital, and I'm sure the other VTE committees across Ireland at the moment is we're trying to get a VTE card to every single patient in the hospital. So it's so people know what a clot is, first of all. And I suppose from sitting here earlier, I suppose it's a bit frightening to hear that people didn't know what a clot was until they actually had one. So it's trying to improve the education around that, what the risks are, when the risks are further increased, and then the signs and symptoms of a blood clot and what to do if you have one. So this is an example of our Cardex in Connolly Hospital. So previously, a risk assessment would have been done obviously by the medical team. So when a patient comes into the hospital and they're not on a blood thinner, so they're coming in for surgery or anything, they'd say, okay, should this person be on Clexane to prevent a blood clot while they're in the hospital, or do they have bleeding risks that would prevent them from being on a preventative Clexane dose? So what's been developed over the last few months was we developed an actual page into our drug chart that makes the medical teams fill this out when a patient comes in. So they have to fill out what the patient's risk factors are, and then they have to fill out if there's a bleeding risk. So if you hit any of the risk factors, you should be on prevention. Or if you hit any of the bleeding risks, it's probably a contraindication. So some of them would be like if your platelets that help your blood to clot, if they were really low, you'd be at an increased risk of a bleed, so you'd want to avoid it. And then there's the treatment options. So they'll either treat with enoxaparin, so Clexane. VTE prophylaxis is not required, or that should really read not appropriate. Bleeding risk outweighs the VTE risk, or they're already on another anticoagulant. So if you're already on a treatment dose of Eliquis or rivaroxaban, you won't be getting injections into your tummy when you're in the hospital as well, or you shouldn't really at the same time. And then, as part of this risk assessment, we're asking the teams to fill out, has the risk assessment been done and has the patient or carer been counselled? So that's really important that we're trying to push, that it's not just a risk assessment and I know sometimes I speak to patients in the hospital and they say, I'm getting an injection every day, but I don't know what it is. Like, that's really bad. We should be saying to patients, this is to prevent a blood clot. This is called Clexane. I'm going to show you now how it works, to educate patients a little bit more, and to actually give the patients an alert card. So we're asking the medical teams when they're filling these out to tick that they have given an alert card to the patients, and they have to sign and date it. So I suppose all of this is kind of trying to, improve the risk assessment, that people are on Clexane at the appropriate dose, and also that they're being given an alert card. So at the moment we have a baseline audit is going on. So one of our interns in the hospital is doing an audit on how many people are actually getting these Cardexes filled out. And I suppose based on those results, we'll be looking at, well, if they're not being filled out, why are they not being filled out? So we need to sit down and say, well, what are the reasons they're not being filled out, and try to get into that a bit more. And if they are being filled out, to kind of promote that and further build on it. So there are a number of different reasons to consider one anticoagulant over another. So even in the room here, there could be different people. Some people could be on warfarin, some people could be on apixaban, some people could be on Xarelto. And you might say to yourself, well, why am I on that one and why is this person on another one? There are a number of different things that are considered when the haematologist or whoever it is prescribing you an anticoagulant. So usually one of them is obviously the clinical effectiveness and the evidence for it. The age, your kidney, how well your kidneys work and how well your liver works, because some of the blood thinners are not recommended if your kidney function is below a certain level. Compliance, so compliance is a big thing, because obviously we want to make sure everyone remembers to take their blood thinners. If you miss a dose, you're obviously at an increased risk of a further clot. And some of the medicines are twice a day and some of them are once a day. So for someone that might say, well, I never remember to take my cholesterol tablet at night, I only remember my morning tablets, we might say, okay, well, they're probably better off on a tablet that's once a day rather than twice a day. So it's simple things like that. Interactions. So some of the blood thinners, and particularly warfarin, interacts with a huge number of medications. So that is considered when they're selecting which blood thinner you end up on. Side effects, monitoring, so how often you're going to need to be monitored. So I'll get into it in a few minutes, but I suppose warfarin, there's quite intensive monitoring, and anyone that's on warfarin will know you go to your warfarin clinic, you get your INR checked. It's not the same for the DOACs or, the oral anticoagulants, the other oral anticoagulants. They don't need the same level of monitoring, which can be really useful for patients, particularly those that might have challenges in getting to the hospital or might need a carer to bring them and things like that. Swallowing difficulties. So if there are swallowing difficulties, some of the oral anticoagulants are suitable for crushing and to be administered that way, and some of them aren't. So that's another factor to consider. Reversal agent availability, I'll talk a bit later on. Falls history and a history of stomach ulcers. So if you have a falls history, so this particularly for older adults, if they have fallen before, I suppose they're at an increased risk of a bleed. So the choice of then the blood thinner will depend on that as well. So just to start with warfarin. So anyone that's on warfarin will know that there's a few different strengths. You have your 1 milligram, 3 milligram, and 5 milligram tablets, and they're different colours. There's 2 different brands of warfarin. There's Warfant or Teva. So Warfant is a round tablet, and Teva is kind of an oblong, it's kind of like this. It's really important if you're on warfarin that you stay on the same brand So if you are on a Tiva brand, so the oblong one's kind of like this, if you go into hospital and they suddenly start giving you a round one, it's worth just saying to the nurse or the doctor or the pharmacist, that's not the one I normally take, because they'll either need to increase your monitoring or they need to get you the one that you normally take. And I suppose then in terms of, obviously when you're going to a community pharmacy to get it dispensed, just make sure that you're not being given a different one every month, because it can affect your INR level. So how warfarin works is it's a vitamin K antagonist. So that means vitamin K is basically needed for the blood to clot, and warfarin basically interferes with vitamin K, so it stops the blood from clotting. It's taken once a day, at the same time every day, usually in the evening, and it's individualised dosing. So no two people will be on the same dose of warfarin. It totally depends on, as I said earlier, your other drug interactions, your diet, your kidneys, your liver, and obviously your INR. So the INR is the blood test that you get when you're on warfarin. So you normally go to a warfarin clinic, they check your bloods, and they check this thing called INR, and it's basically how long it takes your blood to clot. And then the dosing is based on this blood result. It's really important for anyone on warfarin to always inform the warfarin clinic if you've had any changes to your medication or diet. So I'm not talking about like small changes to your diet, like, oh, had 3 bars of chocolate yesterday and, not today. I mean major changes. So if you're suddenly, say you decided you're going to do a vegan diet, like it's really important to let the clinic know about that. And also, obviously, if any medications have been added to your list or taken away from your list, that they know. So interactions, so the effects of warfarin can be reduced by vitamin K. Because warfarin acts on vitamin K, if you eat a lot of, I suppose, food with vitamin K in it, it's going to affect your INR. So it's to avoid large amounts of leafy green vegetables. And I'm sure anyone on warfarin will have been told this before, or I hope you have been told this before. It's all about keeping your diet consistent, so avoiding massive changes. Avoiding cranberry juice because it interacts with warfarin. Alcohol, heavy drinking can either reduce or increase the effects of warfarin. So if you reduce the effects of warfarin, you're at an increased risk of a further clot. If you increase the effects of warfarin, you're at an increased risk of a bleed. And smoking as well can interfere with the INR for warfarin. Up there on the right-hand side, you'll see the oral anticoagulant therapy booklet. So anyone on warfarin really should have one of these booklets. Sometimes they're called yellow booklets or warfarin booklets. And it's basically a way the patients can record what their INR was and what dose they need to take until their next clinic appointment. And there's also useful information, obviously, about the drug itself in there as well. So this is one of the leaflets that Thrombosis Ireland have, and I think they're on the table there as well if anyone wants to take one on the way out. And it's really just straightforward information on potential interactions, what the warfarin tablets look like, and information about illness and travel and things like that. So then to move on to the direct oral anticoagulants, or DOACs. So the first one is apixaban, or Eliquis. So Eliquis is the HSE preferred DOAC, and the reason for that was they've done kind of comparison studies and looked at one compared to the other in terms of cost and effectiveness. HSE prefer this DOAC. However, that doesn't mean if you're on a different one, it doesn't mean it's wrong. It could be entirely appropriate for your condition, and they all have very, I suppose, similar effectiveness. With the apixaban, it's a twice-day dosing. So anyone that's on it will always be on it twice a day. You should never be on it once a day. If you ever end up in hospital and someone gives it to you once a day, there's something wrong. And it's usually 12 hours apart, so morning and nighttime. It doesn't matter if you take it with or without food. And the main thing with Eliquis or apixaban is the kidneys just need to be checked every few months. So with apixaban, there's 2 different doses. Most people are on 5 milligrams twice a day. But if your kidneys are a little bit off, or if you're below a certain weight, or if you're above a certain age, you might be on 2.5 milligrams twice a day. Apart from that, apixaban or any of the DOACs don't need any other regular monitoring. So they're not like warfarin. You don't need to go every week or every 2 weeks to the clinic to get your bloods checked. You're literally put on your blood thinner and your kidneys are checked every now and again. So for anyone that has been on apixaban or Eliquis for a clot in the leg or a clot in the lung, so PE or DVT, usually you're on a higher dose for about a week, and then it drops down to a standard 5 milligrams twice a day dose and the duration can be, like we discussed earlier, it could be 3 months, it could be 6 months, depending on if it's a provoked clot or unprovoked clot. Or for some patients, it could be lifelong, but at a lower dose. Then Xarelto or rivaroxaban. So this is a once-a-day dosing tablet. So for some people, this might be a preferred anticoagulant because if they have difficulty remembering to take tablets twice a day, the once a day will help to improve their compliance. However, for VTE, you'll initially be on it. When you first get a clot and they first start you on it, you're normally on it twice a day for 3 weeks, and then it drops to once a day. It should be taken at the same time every day and with food for the 15 milligram and 20 milligram doses. So the food helps to improve the absorption in the body. And again, the kidneys need to be monitored every now and again, but there's no extra real monitoring required with it. The other one is Lixiana, or edoxaban. Again, once a day tablet. You can be on a 60 milligram dose or a 30 milligram dose, and that again depends on your kidneys, your age, your weight, with or without food, and the kidneys need to be monitored. So you'll see there's a bit of a theme here. The DOACs is new, just keeping an eye on the kidneys and no other extra monitoring. And then Pradaxa. So Pradaxa is twice a day. One kind of important thing with Pradaxa is if anyone is on it, just to keep them in the silver foil of the blister strip. So I know if anyone's on a blister pack, just make sure they're not being popped into your blister pack because it helps to prevent, so it's to do with the water getting into the capsules and things like that. So you only should take them out of the foil once you're ready to take it. And there's 3 different strengths of Pradaxa as well. So there is a DOAC leaflet available from Thrombosis Ireland on the website, or there might be one there, and there's one on the individual DOACs as well. So then just to chat about reversal agents, so antidotes. So hopefully no one will ever be in a situation where they need to have an antidote, but if you were accidentally to take too much of a blood thinner or you were bleeding significantly, which we'll chat about in a few minutes, there is a reversal agent for dabigatran. It's called idarucizumab, a bit of a mouthful, or the reversal agent for warfarin is vitamin K. There isn't a reversal agent for apixaban, rivaroxaban, or edoxaban in Ireland. However, most patients don't present with severe bleeding with the DOACs because when they're taken correctly, they're very safe. So interactions. So in general, for all of the blood thinners, this includes warfarin and the DOACs, there are a number of interactions, so it's really important that everyone's aware of them and that you kind of query them if you think that you've been started on a new medicine. So one of them is NSAIDs, so anti-inflammatory medications. So, for example, the likes of Nurofen that you can buy over the counter, or like Disprin, or things like that. Those medications themselves can increase the risk of a bleed. So if you're on a blood thinner as well, you're at a higher risk. Now, saying that, the odd time, sometimes a doctor will prescribe anti-inflammatory medication for you, knowing that you're on an anticoagulant medication. And that's okay once they're aware. But if someone is not aware, or if you're going into a pharmacy and can I have a box of Nurofen, please? Make sure you speak to the pharmacist and say that you're on a blood thinner, because often they shouldn't sell you a box of ibuprofen if you're on an anti-inflammatory, if you're on an anticoagulant medication because of the risk of bleed, unless it's prescribed by a doctor. Antibiotics. So some antibiotics can either increase the effects of anticoagulants or decrease the effects. So if you're starting on an antibiotic, so if you're in your GP and they're starting you on an antibiotic, just make sure you double check with them. Is this okay with my anticoagulant medicine? I'm on warfarin or I'm on apixaban. It's never any harm to remind your GP that you're on a blood thinner, even though it might be on your record and they might see you regularly, just to kind of flag it. Over-the-counter medicines, so any medicine that you're buying in the pharmacy without a prescription, just if you are on an anticoagulant, it's really important that you say to either the person that's selling the medicine over the counter or ask for the pharmacist and just say, I'm on whatever it is, can you just double check that that's okay with the medicine I want to buy is okay with that medication. Same with herbal medicines or vitamins. And this is particularly for warfarin because some of the vitamins have vitamin K in them. So if you're taking a multivitamin, make sure you don't take one with vitamin K because warfarin is a vitamin K antagonist. If you take a multivitamin with vitamin K, it's going to affect how your warfarin works. And again, there's a huge number of interactions with warfarin. Always inform your clinic of medication changes. So your community pharmacist is always there. I think it's really important, if you are on a blood thinner medication, that you link in before you buy any medicines, and just simple things like telling your dentist you're on a blood thinner. So I think sometimes people can forget that. You go to the dentist, and I suppose we just don't think of it, but if they're extracting a tooth, you're going to bleed more if you're on a blood thinner. So it's really important that they know that beforehand. And obviously, if you're going into hospital and going for surgery, just to make sure that everyone knows. I'd shout it from the rooftops that you're on a blood thinner. So just so everyone is aware that you're on a medication that can increase your risk of a bleed. So side effects. I know everyone always says, you know, you can read the leaflet and there's hundreds of side effects. Most people tolerate anticoagulants really, really well. The side effects are very minor. Some people might experience a bit of nausea when they start them, a bit of dizziness, but generally speaking, most people don't have any issues with them. The ones I just wanted to touch on were ones that if you experience them, you need to immediately contact your doctor. So these are unexpected or uncontrollable bleeding. Now, obviously, if you're bleeding uncontrollably, that the first thing you go to is either A&E or your doctor. Coughing or vomiting blood, black stools or blood in the stools, because that can be a sign of a bleed in your tummy, blood in the urine, unexplained or severe bruising. So if you're on a blood thinner, you're going to bruise a little bit more than normal. So if you were to fall, you will bruise more than an average person that isn't on a blood thinner. But I'm talking about here unexplained bruising. So if you were to come out in a bruise in a random place, say the back of your neck, and you're saying, I don't know how I got that, that's just something to flag with your doctor. You shouldn't be coming out in bruises in places where you haven't, hit off something. Severe headaches, severe nosebleeds, and that's an interesting one because we do DOAC counselling with patients in the hospitals. For example, if someone is started on a blood thinner, the ward will contact the pharmacist. We go up to the patient and we discuss the blood thinner with them and what, how they should take it and the side effects, all of the information I'm going through today. And one of the questions I often get asked is, are nosebleeds not normal when you're on a blood thinner? They're not normal. You shouldn't have nosebleeds while you're on a blood thinner unless that's normal for you. So if you always had nosebleeds, then that's fine. But if they've only started since you've been put on a blood thinner, that's something to speak to your GP about. And then paleness, dizziness, or weakness. So just some general points then to touch on. So I can't stress enough the importance of compliance. So compliance, remembering to take your medication as prescribed. I'm sure you guys have loads of ideas on how is best to remember to take it. Some people have reminders on their phone. Some people put them in a blister pack. Some people have a calendar in their house to remember them, or some people just have a great memory and remember to take them. But any missed dose of a medication increases your risk of a clot. So it's just really important to remember to take them at the right time. You should never double up on a dose. If you forget to take one of the tablets and you say, well, I just take another one today, definitely don't do that because it increases your risk of a bleed. Duration, so we touched on that a little bit earlier. So you should always check when you're started on a blood thinner how long you need to take it for. And I think that's something we need to improve in the hospital as well, is communicating that to patients, because often it's not clear how long someone should be on them for. And you kind of go away, and I'm sure patients leave the hospital and say, I actually don't know if I'm supposed to be on them for 3 months, 6 months, life. Who's going to follow me up? How do I know where to go? And I know that was one of the questions earlier, is you're just kind of left in limbo and you're like, do I stop it? Do I not? And what I always say to people, we as pharmacists on the ward, we try to get clarification on that before the person leaves the hospital. So we say, you're to be on it for 3 months, 6 months, whatever it is. Make sure you don't stop it without speaking to someone, and you need to get a follow-up appointment with your haematologist or your GP or that. Swallowing difficulties, again, there are options. If you have difficulty swallowing, discuss it with your pharmacist or GP. Pregnancy, so the use of warfarin or any of the DOACs isn't recommended in pregnancy. It's really important that you discuss it with your GP or haematologist if you're planning a pregnancy. There are other options. It's usually the clexane at a therapeutic dose, a treatment dose and things like that. And then hobbies, and I know there's a question earlier, or maybe it was just mentioned in one of the lectures about, someone got information that they're not allowed to have a hobby anymore, you're not allowed to do any sport. It's not true. You can obviously, to improve your mobility, activity, it's so important to prevent a further clot from happening. It's just to avoid contact sports. So anything that you might be more prone to an injury or a bleed, to kind of avoid those things. So for example, if you're, I don't know, rugby, if you're playing rugby and you're more likely to fall and bleed. It's just something to be aware of. So just some useful references. So obviously the Thrombosis Ireland website is absolutely fantastic. There's a number of different patient information leaflets there as well. There's if anyone has atrial fibrillation, there's a booklet on atrial fibrillation, anticoagulation and atrial fibrillation on the Irish Heart.ie website. And then at the bottom here, can I just get a show of hands? How many people have a patient alert card that are on or were on a blood thinner, and how many people actually keep them on them? Yeah? A few? Okay. So if you're on a blood thinner, it's so important that you keep a patient alert card on you. So either in your purse, your bag, your wallet, wherever it may be, on your phone. Some people take a picture on their phone. Wristband, yeah. That, God forbid, if you were in an accident, someone would know you're on a blood thinner straight away. And that would help to improve the management of that as well. And again, as I say, the minute you go into hospital, to make sure, I wouldn't be afraid to tell every person that you're on a blood thinner and that they know that. So that's it, everyone. Thanks so much for listening. I'm happy to answer any questions you might have.
I just have one that just came in over the phone. Michelle has asked, is it safe to take Q10, CO-Q10, if you have a recent history of VTE and are on an anticoagulant?
As far as I know, yes. Now I can double check after and get back to you, but yeah, I don't CoQ10 is normally not a problem.
Okay.
Yeah,
That's grand.
I think there was a question behind you there, Anne-Marie.
Yeah, it's the measurement of INR.
Yeah.
I was told by my GP it was too high at one stage and to go off the medication
Okay.
for 3 days. But then I was in the musculoskeletal unit in Harold's Cross, and they were taking bloods every day. And they said, your INR is very low, why are you? But they were doing the test by a pinprick. And I later learned through the internet that the pinprick is not reliable.
Yeah, it's not as accurate as a blood test from your vein. Yeah, the pinprick.
Particularly in somebody that's been treated for APS.
Yeah, no, you're right. It isn't, and I suppose
But they didn't seem to know that in Harold's Cross. It was only when I came out.
Okay.
You know, so
Yeah,
I think some of the medical personnel need to be
educated on that, yeah. And I know in Connolly at the moment we're having there's a brand new system coming in for blood tests where it will be pinprick, but it's all validated. So it means that it's going to be more accurate in terms of when they check your warfarin level, your INR through the pinprick, it's all validated against labs. But you're right, it is something to kind of flag with them, especially if they're going to be changing your dose of warfarin based on the INR. Yeah. Because especially if you're very stable before you go into hospital, your INR is fine, you take the same dose every day, and then you go into hospital. Now, it can be dietary changes in hospital. It can be new medicines they're giving you that can affect it. But if there's significant differences, it definitely is worth saying, can I get a proper blood test to check my INR? Because, yeah, the validation mightn't be as accurate.
But tell me, is it still the case that warfarin is the only anticoagulant you should have if there's a suspicion that you might have APS?
I think, yes. I think the evidence is strongest for warfarin. So the warfarin is a fantastic drug, and the reason why we've moved away from warfarin in the last few years is the DOACs, the newer drugs that have come out, they don't need the monitoring, which is great for patients, but for some conditions like APS and some of the other ones, you need to have that extra tight monitoring, and warfarin is the only one that you can check how well the warfarin is working. So with the DOACs, you nearly assume they're working perfectly. And the studies have shown that they do work perfectly when they're taken at the right dose. But for patients that have a specific condition or maybe have issues with compliance, it's really important that the INR gets checked. So you can say, no, that person's INR low, I need to increase the dose or decrease the dose or whatever it is. So I think for APS, I think warfarin probably is the best choice in terms of the tightness of monitoring. So
Okay, sorry, can I be greedy and ask a third question?
Yeah, of course.
Is there a brand of multivitamin that doesn't have vitamin K in it?
Good question. I will look it up for you. If you're looking to take a multivitamin, I'm sure there is plenty of multivitamins that don't have vitamin K. I'm not sure if Centrum does, but if you're buying any multivitamin in your pharmacy, just double check with them. You could, to be honest, the writing at the back of them is tiny sometimes. Like, I can barely read it myself. So I think just ask, if you're buying a multivitamin, just say which one of these is fine. There's so many multivitamins available now that you know, you could go into a pharmacy and there's a whole wall of multivitamins and you can kind of look and say, which one do I need to take? So I think if you're going to a particular pharmacy and there is a huge choice, just double check with them which one is okay. Yeah. Yeah. Sorry.
Of switching from warfarin to the newer ones?
So it would usually be a haematologist. So depending on who started the warfarin initially, like I've come across patients before that were on warfarin. Now, sometimes it would be for atrial fibrillation, so slightly different condition, and they've been on warfarin for 20 years, and they've been going in and out to the INR clinic, and to be honest, sometimes the patients are just getting a bit older, they can't go in anymore, and they're saying, can I not go on a new blood thinner? I'd always say, speak to your haematologist, see if you're a candidate for one of the newer agents, the DOACs, because often people are. As I said, some conditions, no. Sometimes if you have like a metallic valve in your heart, or like if your kidney function is really bad, they might just want you to stick with warfarin, but it's always worth asking if you can switch, because it can improve your quality of life. And I know, as I said, warfarin can interact with so many things, and the other oral anticoagulants don't really have as many interactions. So I suppose the impact on your quality of life isn't as high with the other ones. So a haematologist, I suppose, it could be discussed with your GP as well, but they mightn't make the call on it. They might want to refer you back to a haematologist, but it definitely is worth asking, yeah. No problem.
I think anybody who's changing needs to be conscious of the price.
Yeah.
Because warfarin is like €3 a month or something.
That's very true.
And
yeah.
you're talking maybe 80, 85 euro a month for a DOAC. If you have, well, you're paying the 85, but if you already have the drug card, that's fine.
Yeah.
Yeah.
If you have a medical card,
just be conscious of it. I mean,
Yeah.
they are great, and you don't have to worry about getting blood tests, but I think
they're higher
the
cost,
doctors need to be conscious as well.
Yeah,
of
that's
what
actually really true, because sometimes I think people
especially
leave hospital
long term, you know.
Yeah, and people leave hospital sometimes and they mightn't have the means to pay for a DOAC, you know. But there is obviously the drugs payment scheme and the medical card. So the medical card is obviously covered on drugs payment scheme. I think the cap now is €100 a month. 80 it's dropped to, okay. It just shows you when you don't work in community pharmacy anymore, I'm like, these things are all new. But 80, so if you're on other medicines, you might be hitting the cap. But still, €80 a month is a lot of money. So
GP charges €20 every time there's a blood check.
okay. For an INR?
Yes.
Okay.
Even though I have the over 70s medical card,
All right.
they shouldn't.
I don't know about that one, yeah.
I know the other practice further down the road charges €10 per year. Mine charges
20, yeah.
Can I ask you a question too?
Measuring myself for 20.
Can I ask you a question, please, or two? I've recently had a knee replacement.
Okay.
And as a result, I'm having a lot of pain and fluid.
Okay.
So because I'm on the blood thinners, and the doctor, she did prescribe me painkillers, but all of them interacted. I came out with swollen face, yellow, whatever, swollen hands, swollen everything.
Lips and everything, okay.
However, she said she couldn't give me anything for pain, nothing,
Okay.
other than take Panadol. I then returned to the consultant again. I asked him, because reading up on Dr. Google, I thought, okay, he might drain this now. You know, I had a plan going in, but no. He said you could succumb to an infection.
Okay.
But in the meantime, you're left with this, suffering with the pain and the fluid. It's the fluid causes the pain, but it's an anti-inflammatory, and because you're mixing it then with the blood thinners, is there nothing then that can be,
So
is there any hope?
there is. So I suppose it's difficult to comment on your personal situation without kind of knowing the background to it, but anti-inflammatories are ideally a no-go. Their other options are paracetamol, which I know for some people is hopeless. And some people it's great, but I know for others it doesn't do the job. Codeine, so like sulfidine, sulfidol, anything like that. Now, I'm not a massive fan of codeine because it is addictive, it's taken long term, it's quite constipating, but it is a good painkiller. Then you're onto your opioids then. So you're talking about the likes of like tramadol, Did you? Yeah, that's, yeah. It doesn't agree with a lot of people.
Neurontin was absolutely deadly.
Really? Okay.
Absolutely
And
deadly.
yeah, then you have your neuropathic agents like Lyrica and things like that as well. And then you've stronger opioids then going up. So there are choices with painkillers, but it's just about finding the right one for you in terms of what other medicines you're on and what you haven't had a reaction to before. So I don't know, I can maybe chat to you after if you want to we can see if there's anything.
Just nothing.
I know, no problem. Sorry, yeah, me too.
Hi,
Hiya.
I take Rivaroxaban, and I'm just wondering, I like going to the health shop for little health remedies.
Yeah.
And it's okay to...
I think it's worth checking with your pharmacist. Just if you bring your herbal medicines with you, whatever you take from the herbal shop, bring them to your local pharmacy and ask them to check for interactions with your Rivaroxaban. I think, I think there is sometimes people think, the herbal medicines are fine. Sometimes they can interact. Now, usually the major interactions are if people are on warfarin with the herbal medicines, but I think it's definitely worth checking just to make sure.
Yeah, thanks.
No problem.
I'm last question.
Yeah, no problem.
I had a blood clot last year and I'm on a big span, but I have a lung problem and I am on Nitaban. I don't know how to pronounce it.
Oh yeah,
Sure you-
Nitaban, yeah.
Yeah, I think that's how you pronounce it. But it says on the thing that it shouldn't be taken with blood thinners. But I said it to the girl in the pharmacist and she said, they say that and everything, not to worry about it.
So I think it's, I can chat to you again after and we can have a look at it. But do you have that medication with you?
Well, I
Yes.
have the name of it.
Yeah, I'll have a look after.
Yeah,
But
yeah.
some of the interactions, so a lot of medicines can interact with each other. Some of them are significant interactions where we'd say definitely not happy with that needs to be changed. Or some of them are less significant and you'd say to someone, so for example, you might have a blood thinner and a certain antibiotic.
Yeah.
And if I put it into an interaction checker, it'll say, avoid use together.
Yeah.
Increased risk of bleed. But I might say, well, that's the only antibiotic that person can have. So that's appropriate for that person. But I'd say to you, look, keep an eye if you've increased bruising or bleeding. So some of them, a clinical decision will be made to continue it, even if there's an interaction with extra monitoring. And sometimes it's literally just a no-no. So I'll have a look at that later. Yeah.
I get blood tests done every month. So
Okay.
would that show up anyway?
It probably wouldn't.
Would not.
An interaction wouldn't show up. They'd be checking your kidneys, your liver and things like that. But we can double check the interaction. I'll just make sure.
Thanks very much.
Yeah, no problem. Thanks a million. Thanks everyone.